Welcome to part 2 of this video series, during which we will discuss the clinical impact of herpes zoster and its complications. We will first discuss the potential impact of adult herpes zoster, and then turn to postherpetic neuralgia and other long-term complications. But first, let's meet a patient, Nora, who has had a particularly severe case of herpes zoster. She's 66 years of age, presents with a vesicular rash running from her back to her waist along the T9 and T10 dermatomes. She says that the rash is extremely painful and characterizes the pain as intense, constant, stabbing, and unresponsive to NSAIDs. She states that the rash first appeared as red bumps about 4 days ago, but because of the pain, she has been unable to drive or even perform light housework. Now, we're going to come back to this case later, but first I'd like to ask Stefan, what is the clinical course of herpes zoster?
So the prodrome, even before the rash appears, can be pain or other kinds of symptoms, and they can last for 2 or 3 days before you get the first vesicles. Once the vesicles come around, you get 3 to 7 days of that, and those then become pustular, and that lasts for up to a week, and they can crust over. Another week passes, and finally you can have a resolution of the rash, which takes a final 2 to 4 weeks for complete resolution. There are some people, of course, that go on to have secondary symptoms, which we'll talk about later. So the prodromal phase occurs before the virus invades the dermis, and that's why you don't have a rash yet. So you may have other kinds of symptoms, such as itching or hyposthesia, or paresthesias, or burning, or just pain. And that will occur typically in a specific dermatome, that is the dermatome of the nerve cells that contain the virus. Then the rash appears, and this is typically unilateral, and the size and distribution varies. Pain is typically described as burning, aching, tingling, stabbing. Occasionally, you don't get any rash at all. They can go clear up without getting any rash. The virus is transmissible once you get vesicles. And this virus is the same virus that causes chickenpox. It's a reemergence of virus that has been dormant. And that is transmissible until the rash crusts over. And here you can see pictures of the early stages when the vesicles are just beginning to appear. A rash with plenty of lesions. This looks like probably 30 or 40 lesions in the middle frame. And then the crusting over on the right, no longer contagious at that point. So the classic presentation is with vesicular dermatomal rash and neuralgic pain. If you want to do laboratory testing, I think it's indicated if you're confused about what the rash represents. Sometimes you can have lesions that might resemble impetigo or something else. And if you're not clear, you do want to get a sampling of the rash, and probably the test you want to do is PCR. PCR is highly sensitive and specific, and the best thing to test from that is the vesicular fluid. You can take some of the crust. You could also get a tissue biopsy, or if they have neurologic symptoms that you're not sure about, CSF fluid, if you're expecting this interdifferential for a meningitis, would be appropriate. When you think about your most difficult patients, what kind of patients are there where the differential is hard for zoster?
Well, actually, the most difficult is when they don't even develop the rash. I mean, we see a percentage of patients who present with pain along this dermatome. I mean, they could have pain that could mimic myocardial infarction, acute appendicitis, and maybe the rash doesn't even occur. I mean, then laboratory tests, serologic tests, PCR tests, actually CSF would probably be the best there. Can be helpful in distinguishing that cause of pain. But fortunately, that pain usually resolves after a period of time, even if it doesn't have the rash. But I think if it is a rash, I think the biggest is what you've already mentioned, differentiating other sort of vesicular or pustular lesions, most specifically staph, and particularly with the advent of community-associated MRSA, over the past decade or so, that has always been a big differential. And we also know that if you do develop zoster, they are at higher risk for developing secondary bacterial infections. So you actually may have both.
Yeah, for me, it's, I always, I think, run into trouble with the immunocompromised patients because my differential of all the infectious diseases skyrockets, and thinking about whether this is zoster or not often gets missed.
Yeah, and in those patients particularly, it may be an atypical form of a rash. I mean, we may see large bulli and not just the small little vesicles in those particular patients, which makes it look atypical as well.
So your diagnostic challenges?
Well, we've already mentioned the prodromal pain that may suggest other conditions. We mentioned acute appendicitis, cholecystitis would be another example from a potential intra-abdominal differential. Myocardial infarction, we said, or some chest, even pulmonary emboli. I've had difficulty sometimes considering that because of a pleuritic chest pain. Trigeminal neuralgia, which would be up in the face area, can be a very severe issue and may mimic migraines, for example. And then we've already mentioned the skin manifestations, such as differentiating from impetigo or even contact dermatitis. And then, of course, HSV, I mean, herpes simplex. You can actually get herpes simplex that may be somewhat linear and maybe just localized unilaterally on one part of the body. That can be difficult to differentiate from herpes zoster as well. And we already mentioned the mimicking of community-associated MRSA. So as I said, I've seen several patients for whom this differential has been difficult. I recently saw a patient who had cellulitis of the face, and it actually involved the nose, so we were quite concerned. Could this be a manifestation of the trigeminal nerve ophthalmic division of a zoster, or is it true cellulitis, sort of erysipelas type of a picture? And so that can be a difficult differential, as we've already mentioned.
So the impact of acute herpes zoster. Neuritis with pain that may be severe is one of the things that is front and center. And the thing we don't think about that comes with pain is functional impairment. When you get functional impairment, this means an impact on physical, social, role, and emotional functioning. You get people who are no longer able to do the things that they usually do to get through life. So this affects their quality of life. The greater the pain burden, the poorer the function, and the more emotional distress they have. Some older individuals may experience permanent loss of independence from this, and it is really profound when you see somebody that's completely disabled by their zoster. So here's a slide that shows the effect of acute herpes zoster on activities of daily living. And this is done by two sort of mixed methods approaches for measuring functional impairment and stratified by the severity of pain. So the left pair of bars has no pain. The second set has mild pain. The third set, moderate pain. And the right-hand set has severe pain. And the vertical height of these bars is how much functional impairment they have. And you can see that on the severe group, 2/3 to 3/4 of them will have substantial functional impairment. So I think the point here is that pain affects function in profound ways, and that it's more than just treating the pain, it's actually keeping them viable members of the community.
Now we know that using antiviral therapy can reduce the duration of the acute zoster episode. We know that these agents are most effective if we give them within the first 3 days. And the agents include acyclovir, famciclovir, valacyclovir. I always consider these very attractive antimicrobial, in this case antiviral agents, because they of themselves are inner drugs. I mean, they are not active when they go into normal cells, but if they go into cells that are infected with herpes, the herpes produces a viral-encoded thymidine kinase, which can phosphorylate these drugs, which are then further phosphorylated by cellular enzymes into a triphosphate form, and that's the actual form that inhibits the viral replication. So the bottom line is if you don't have herpes in the cell, they're not going to cause any problems with the cell generally. So they're relatively safe from that standpoint. They're only active in cells that are infected with the herpes. I've already mentioned that the best benefit is the earlier treatment. However, I certainly would continue to give therapy or even initiate therapy on day 4, day 5, day 6, if I see still new vesicles occurring, I am going to initiate therapy with those antiviral agents. We know that, as I said, it reduces the duration, probably reduces to a certain extent the acute pain associated with the acute episode, but it's unclear if it prevents post-herpetic neuralgia, which is a major complication, as we mentioned. And we know that 20% of the patients continue to have pain at 6 months, even if they've used those agents. And so then we have to consider pain management. And there are several different approaches. I mean, we can use NSAIDs for mild pain. A lot of patients will be treated with opioids, but there's lots of controversy there about overusing opioids, as you know. Glucocorticoids have been used in the past decades by many, and there were studies earlier, a couple decades ago, suggesting that the use of a tapered dose of steroids may improve quality of life, but there was a recent meta-analysis that suggested that really wasn't the case. So I really don't give steroids now to patients who have acute zoster. Do you, Stefan?
No, I don't anymore.
Yeah. So at least in my experience, the best has been these anticonvulsants, such as gabapentin, and I found that to be usually helpful. How about yourself?
Well, we use a lot of gabapentin at my institution. I like using actually capsaicin cream.
Okay.
And that is effective against other types of peripheral neuropathies and has the advantage that it isn't systemically absorbed. So in my oldest patients who are already possibly a cognitive impaired state, it doesn't impair them quite as much.
Yeah. And then, of course, if you have refractory pain, sometimes patients have to go to anesthetic nerve block, but then you'd have to refer them to a pain specialist.
Right. So when we think about the complications of acute zoster, we can divide these into 3 or 4 categories. If you stick ophthalmic in with neurologic, it would be 3. But the ophthalmic category is important enough that really it should be thought about separately. For the ophthalmic part, there's stromal keratitis, iritis, retinitis, visual impairment, episcleritis, and keratopathy. For the neurologic otherwise, the remainder of the cranial nerves, including cranial nerve palsy, post-herpetic neuralgia, which is long-standing pain, motor neuropathy, encephalitis, transverse myelitis, and post-herpes zoster stroke syndromes. For the cutaneous forms, there's bacterial superinfection, permanent scarring, and changes in pigmentation. And then finally, the visceral types of complications are pneumonitis, encephalitis, and hepatitis.
Yeah, and I would like to comment that we're now becoming aware that HSV encephalitis is a very common cause of encephalitis in older patients. It's actually more common than HSV, or herpes simplex encephalitis, so it's something that we always check when we see these patients and evaluate their CSF for zoster, or at least varicella zoster PCR.
And do our antivirals penetrate the blood-brain barrier?
Yeah, they do, but we have to use larger doses, and it's all IV.